Our next speaker will be Dr. Khochikar from Miraj, India, who will be discussing penile, testis, and urethral cancer.
Mr. President, Secretary, members, and distinguished guests. It's a great pleasure and honor to be here in front of all of you to give a take-home message on penile, testes, and urethral cancer. I have looked into the plenary sessions, the various abstracts, the videos, and other presentations in the section meetings, and I'm trying to give you an overview what's new, what's hot, and what's really not. In terms of penile cancer, we had a wonderful meeting of Society of Urological Oncology, where we know we had European urological guidelines for penile cancer. But the emphasis here in this meeting was on NCCN guidelines, and I encourage all of you to go on the website of NCCN to look at the new updated guidelines for the penile cancer. Having had these sort of new guidelines, still the controversial issue of management of N0 groin, negative groin, still remains a controversial. There was a debate both in a plenary as well as in ACO meeting on the management of bulky inguinal lymph node masses, whether we should resect them so that there is no fungation and the patients undergo TIP chemotherapy versus neoadjuvant chemotherapy followed by surgery. And I think the debate was fiercely debated here, and I think if you select the patient carefully, you can choose neoadjuvant chemotherapy, which is found to be fairly useful. I would like to bring your attention to IMPACT trial, which is going to take off in 2016. And this is probably going to address some of these issues of bulky lymph node masses as well as N0 groin. We always believed that local recurrence in penile cancer is quite low. Corporal margins in case of partial penectomy, we have been thinking that it should be at least 2.5 centimeters. In EAU guidelines, it came down to about 2 centimeters, and it was discussed in a SEO meeting and as well as NCCN guidelines, even 1 centimeter or less corporal margins is not that detrimental and acceptable. Rather than old chemotherapeutic regimes, you could have TIP 4 cycles, which has paclitaxel, ifosfamide, and cisplatin found to be effective. Prophylactic pelvic lymph node dissection in case of penile cancer was a very good abstract from Netherlands. They had about 79 patients. Preoperative imaging was normal. 24% of patients, despite negative imaging, had pelvic lymph nodes positive, and the criteria or the predictors of positive pelvic lymph nodes was more than 2 inguinal lymph nodes positive, extranodal extension of pelvic lymph node involvement. But I think we all know the 5-year disease-free survival rate in these patients is dismal in the range of 17%, and maybe this neoadjuvant and adjuvant chemoradiotherapy may be some sort of hope in select group of patients. And this is a graph which showed if you have a negative pelvic lymph nodes, the outcome is better. If you have positive, they really have a worse outcome. It was interesting to see the SEER data from Chinese group, where they looked into nearly more than 1,200 patients, and those patients who have undergone local tumor excision, what they called as LTE. About 24% of the patients underwent local tumor excision, either in form of excision or partial penectomy. And what they've noticed that there is increasing trend towards a local tumor excision for T1 lesions, that's 29% to 40%, and nearly 4-year penile cancer-specific mortality in these patients was about 9.8%, suggesting that local excision is underutilized, and now we know the redefinition of positive surgical margins or negative surgical margins in penile cancers. More and more patients can be sort of encouraged to have partial penectomy. What about imaging in penile cancer? And this was a good paper from Oklahoma group, and it suggested that unnecessarily we do more and more number of patients getting an MRI scan in the follow-up. NCCN guidelines and EUA guidelines suggest that there shouldn't be much use of MRI, and the risk-based use of CT and ultrasound, if required, ultrasound-guided lymph node biopsy. We all know that pelvic lymph node during pelvic lymph node dissection, if there is extranodal extension, they have a worse outcome, and adjuvant chemotherapy may have slight chance of better survival. What fascinated me was this optical biopsy of suspected penile cancer using confocal laser endomicroscopy. We know its use has been utilized in kidney as well as upper tract TCC. What they use is use an intravenous furosin, use a probe, which is about 2.6 millimeter, 3 patients were done with this sort of a technology, a new technology, and you can see, you can predict the histology, especially carcinoma in situ, and probably this is going to the future. What are the factors associated with suicide in patients with GU malignancies? This fascinated me quite a lot. And I thought patients who have undergone penile malignancy surgeries, or perhaps testicular malignancy surgeries, may have tendency towards suicide. You have a big pendulum which is going from depression to sort of suicide to aggressive varieties, aggressive behavior. But what has been found that patients who have bladder cancer have a highest incidence within first 5 years, as well as prostate cancer, highest incidence 15 years after the initial diagnosis. We know urethral cancer is extremely rare. There is 2 good papers which I have selected. One is substitution urethroplasty for a distal urethral carcinoma and carcinoma in situ from the UK group. They had about 21 patients with primary urothelial carcinoma of the urethra. Some of these patients have extension from penile cancer. What they did was they excised this urethra, used a buccal mucosa graft, and repaired that, formed a tube either in 1 stage or 2 stages. This is the first reported series of urethral preserving surgery in urethral carcinomas. What the point of concern to me was, there were about 2 patients with T2, 2 patients with T3, and they had, despite negative frozen sections, they have 33% positive margin rate. There has been an impact of perioperative chemotherapy on survival in patients with advanced primary urethral cancer. We all know that urethral cancer is extremely rare. Only 38 patients have been sort of found so far in such a huge period of time. And likewise, cystectomy, these patients also do fairly well by using a perioperative chemotherapy followed by surgery. Lastly, about testicular cancer. Development of intermediate and high-risk prostate cancer after testicular cancer. We just heard there is no correlation between vasectomy and sort of prostate cancer. But now this data, which came from Baltimore group, suggested that they looked at about nearly 147,000 patients as a control for melanoma, because this has no correlation with prostate cancer, versus 32,000 patients with testicular carcinoma. 15 years after testicular cancer treatment, and cancer prostate was diagnosed in more than 3,000 patients. And they also found that the higher incidence, if there is an intermediate and high-risk cancer in patients with testicular cancer. What remains unanswered is basically what kind of stage of the disease, what kind of chemotherapy, radiotherapy, and surgery these patients had. And this is how it looks like. Compared with melanoma, as compared to testicular carcinoma, the incidence is much more higher, but we don't know what the treatment details are. It was exciting to know that we know that post-orchidectomy, there is a disruption, pituitary-leydig axis dysfunction. But this study actually looked at preoperatively. They looked at nearly 95 patients, and they found that even 72% of the patients, even before get their testes out, they had abnormal pituitary and Leydig cell function prior to orchidectomy. And what was more common? Stage 3 and patients with non-seminoma germ cell tumor as compared to seminomas. Use of RP-LEND in the United States, and this is a result from the National Cancer Database. This was a poster by Brian Hugh et al. And they found that the rates of RP-LEND in each stage of different settings are actually sort of looked at different centers. And RP-LEND was seen more in academic centers. You look at this community cancer center, comprehensive cancer center, and academic centers. And this is how it looks like, the utilization of sort of RP-LEND in these kind of centers. Lastly, declining rates of RP-LEND for a stage 1 non-seminal germ cell tumor. This is again a national cancer database. And this suggests that now I think the difference between the European thoughts as well as the American thought is getting closer and closer. We had a debate in the morning, what should we do for a stage 1 disease and a stage 2 disease? The RP-LEND across all the stage group decreased from 23% to 12.9%, while chemotherapy has increased from 20% to 32.5%. So I think people use selectively to have a maximum benefit of therapy. Thank you, AUA, for giving me an opportunity to talk about these topics.